I'm fascinated, on the surgical side, the clinical side. I'm an anesthesiologist. I feel like I have a good knowledge of that part. Just starting really, I feel like getting into the depths of the different ways that patients, show up at the doorstep for these things. As far as getting surgery with referrals and the different levers behind that, that's fascinating to me as well. But I kind of wanted to, I'll go in a little bit more about myself in a minute. I'll start off with something a little bit more interesting. I wanted to kind of get everybody to think about different things that they purchase. Say there is, a certain kind of grocery, certain kind of soda that you like, certain kind of alcohol that you like, a meal. You probably know lots of different places that maybe offer that. Maybe you kind of know their quality. You certainly would know their prices. And so what we want to do is to get people to think about surgery, think about healthcare in more of that kind of way, like in every other industry. Okay, I know I like this, certain bottle of wine. I know that go to Market District we have in Indianapolis. Go to Meijer. Go to Costco. I know there's different prices, and so I know what I'm getting into when I'm getting into it, and that's not how surgery is right now. And I think you guys can all appreciate that. So I kind of thinking of things that way. I kind of want to pull the room for a couple reasons to see, kind of gauge my audience a little bit, see where you are in this path of free market surgery, and also to kind of prove a point. So going over 3 different procedures: a laparoscopic hysterectomy, a lap chole, which is a gallbladder removal, laparoscopic, and inguinal hernia repair. Who here feels pretty comfortable where they know what a good price for that would be? A good price for those specific surgeries? Yeah, got at least 1.5. Oh, 1.5, I suppose. 3. Yeah. So
it depends if you walk out or they roll you out.
yeah. So yeah, that's kind of about what I expected, and I didn't know any of those before, until about 5 years ago. You just got started into this, so yeah, it's amazing that we don't know. We're making decisions, very important, big decisions on high dollar items, and we don't know really what we're even looking at. And maybe you've even had. I had a gallbladder removal 4 years ago, and I only looked at the EOB, afterwards, and it was still tough for me to figure out. If you know those, you said a few people in here had good ideas on what prices were, what a good price was. I have examples here. The first numbers here are our prices that we post on our website, www.wellbridgesurgical.com, and the second prices are actually Indianapolis area prices they're the negotiated discounts that one of the carriers have there, one of the bigger carriers have, the insurance companies. And so that is what you are. So the second price on there is what you're accessing. You're using them as the TPA, or you're fully insured. That's what you're accessing, and that's what you're able to. You're privileged to have that price on the right, and so that price on the right clearly is much higher than the ones we have on the left that are our prices that we post online. And I apologize. I'm an anesthesiologist by trade, so I've got to do a little cheating and looking at my notes, make sure I present this in a good manner for you guys to all learn something. And move on to the next one here. So I know I shared 3 before, and this is just a graph of more of the procedures. So pretty common procedures that people understand what they are, and probably you've either you or a family member or a friend has had one of these procedures. So we got colonoscopies, upper endoscopy, ear tube, carpal tunnel, septoplasty, and then a couple of the other ones that I mentioned already. These we were actually able to see what United Healthcare looked at bundled prices. When it's really hard. I was just talking to a couple of people earlier today. It's really hard to go to anybody, let alone a carrier, and have them tell you what their bundled cost is, what the price is if you go through them, what their network prices are, negotiated rates. But these are the numbers that we've actually gotten that that they're fine with us sharing, and it's roughly 50%. Jeff Williams he's in the back. He's our traveling salesman who goes and talks to different brokers, employers, and that's about what it comes to. I usually say 40 to 60% because it does vary, but 40 to 60% less, or we're about 40 to 60% less compared to the average Indianapolis area negotiated rates that the carriers have, and so I believe that we're about looking at another TPA looked at our prices, and they said the direct contracting were about 40% less than the average direct contracting rates in Indianapolis, and that was an independent TPA that said that. And so I want to also talk about, I think there's a couple reasons that people don't think about surgery and think about price. One, I think that things lack so much transparency. It's the waters are very muddy. It's kind of a fool's errand to really even try to find out what a bundled price is. Maybe you can find out how much the surgeon gets, but to look at like what an average good price is and add those things together is really, really hard. There's a large group in Indiana, the Indiana Employers Forum, and I go to them and talk to them about prices, and they'll say they'll give me some data, and they don't even know what that data is from, or if that's really even accurate. And so even those folks who are really trying to dig a little bit deeper are having trouble finding that out. So I think that people don't think about the price because it's hard to find it out. It's too difficult. We are trying to make it easier. Another reason I think is because most patients, at least individuals, they don't feel the full burden of the cost right there, and so if it's not affecting them right there, they don't really care. They think, oh well, somebody else is paying for it. Is it the insurer, the employer? It's not them, so they don't care that much. Unless they're just kind of worried about their little deductible zone. And what they don't realize is that somebody's paying for it, and people, here I think we're talking about self-funded employers. That employee, what they don't realize, if they're going to a place that is going to charge $50,000 for a total shoulder replacement, when it could have charged when it could have been $20,000, that extra $30,000, there are repercussions for that, and next year they're not going to get a raise because of that. If people make those decisions. They have to know that there are consequences for those decisions. I don't think that people understand that. So I told you I'd tell you a little bit about myself. This is a picture of my family and I. So when I'm not traveling through the states that Justin said that I travel through and drive through, like today, 7 hours up from Indianapolis, I like to spend time with my family. And this is a good time for me because all my kids are at overnight camp and my wife is at a conference in Chicago, so this is perfect timing for me. I am a board-certified clinical anesthesiologist, so I got out of residency in 2010, and it's long enough now that I've got to look back and see because I don't really remember that. And after residency, I worked at two different hospital systems in Indianapolis. Both of them level 1 trauma centers, so pretty big systems. IU Health was one, and Ascension was the next one. I tell people after 4 years of high school, 4 years college, 4 years medical school, 4 years of residency, after about 4 years of practice, I was kind of looking for the next challenge, and around that time, we heard another colleague, as well as myself, heard about the Surgery Center of Oklahoma in Oklahoma City, and a lot of you guys are probably familiar with them. And and saw what they were doing down there and posting their prices online, and how much different that was to what the normal traditional system, or at least within the last 40 years, has become. And we're fascinated by that. We went down and actually visited Keith Smith in Oklahoma City, and he has been very helpful in telling us how he's gone about things and how he's done things the right way. And we figured, hey, we can do this up here, because with a couple different anesthesiologists and myself together, we knew most of the surgeons on the north side of Indianapolis. We knew which ones we would trust, which ones have good outcomes, which ones we'd send our family members to. And so the last kind of 4 years or so has been a journey to get to this point. And in December 2nd, 2021, so 7 months ago, that was our first procedure that we did. We did it was a tennis elbow on a patient who was self-employed, and so him and his wife just had their company, and they were taking care of their own insurance for health care, and it was a pretty amazing experience to do that and have it come to a reality. But that's kind of a little bit of the story behind how we started. You guys are probably familiar with the RAND study, RAND Corporation. It's kind of headed by Chris Whaley, who is a healthcare economist. And May 17th of this year, the RAND 4.0 came out, and it just sheds light on how much healthcare costs, and specifically surgical care costs, within the different states. Jeff and I, when we started this, we didn't even know that Indiana was very high on the list. So out of the 50 states, I think Indiana has been 4th through 6th. So currently 6th outpatient facility prices for surgeries. And what I didn't realize, I knew Wisconsin was high, but I didn't realize they were higher than us until a couple days ago. Looking at this, 4th highest, which is pretty amazing. And so when you have the costs so high, obviously that's a big line item for employers, and so the margins suffer. And not only that, but member benefits. People are you have to have a good culture. You have to have good employees and have them want to be there, and that suffers as well. And so that's why a lot of you guys are here. So you guys know all that, but 4th highest is pretty bad. You even beat us. Congratulations. And so when we talk about employer health plans, I think it's good to say, start over and say, to kind of forget where we are right now. But what are your goals? What in your employee health plan? What are your goals? Where do you want to be? And then we'll think about how we would implement a plan that would do that. We don't have many employees, and I just became an employer. But I would think that high quality health care, having your patients being very well taken care of is your employees being very well taken care of is important. Low cost kind of goes into that previous slide where that allows you to run your business in an efficient manner and to hit the goals that you need financially. That's why people are in business. And ease of access. Not only do you want a very high quality and then low cost, that's where you get the value. You want it to be a smooth process, and you want it to have ease of access. You don't want it to be difficult for your members to be able to access that health care, regardless of whether it's high quality or low cost. So I think what I hear a lot of people say their goals are, as we think about this, and I've even heard, one of our senators in Indiana, Mike Braun, he is a business owner, and so I heard him, give a talk, and one of the things he said, until a few years ago, he kind of really learned more about this. He said his goal every year was, I hope it doesn't go up this percent. I hope it doesn't go up 10%. Only 10% is good. Going up with and decreasing and increasing the deductible while we're at it. That's doing just enough. that you doing just enough so that that we can afford it and not make the employees too mad. I mean, that's kind of what it's become and not what it should be. So if we get that value, so the high quality, low cost, then that creates higher value benefits to the members, to the employees, helps with it, recruitment, satisfaction, retention, which is what we all want. And so, in the current payment system, is the current payment system allowing you to achieve your goals? Fee for service is a problem. It's difficult to decipher. You can look at an EOB and you don't even. Even me being a physician, I can't really decipher it very well. It's so convoluted that employers don't even know what they're really paying for, and they don't know not only what they're paying for, they don't know what the quality is. It's even difficult to say how much they're paying. I mean, the analytics that some of these employers have kind of shown me are pretty ridiculous. They don't. Not only do they not understand them, but when I look at them, they're incorrect and they're presented in a poor manner. You'll ask somebody how much they spend for their colonoscopies, and they'll get data from their consultant that says they spend $400 on their colonoscopies. And what is that? Is that the all-in bundle? They're like, I don't know. Well, that's a big deal because the facility cost usually in Indiana is about 10 times just that, and that's what it was. They just didn't even know it. So it's so convoluted, and it's been kind of set up that way intentionally. I mean, you could say it's genius by the people who are making money off of it, but we're trying to unravel that a bit, and that's why I've got this picture of how forget her name, Griswold. I don't know if it's Ellen. Is that what it is? Yeah, yes, yeah. But yeah, it's kind of like where is this wire going? How is this working out? So it's just, I mean, it's forcing employers to make these big decisions without actual data. It's like spending how should we spend our marketing money? Should we look at what's actually bringing us clients or bringing us revenue? No, let's just spend it on that over there, and then that over there. Just kind of spending it blindly. That's not how business should be done. And then with that unknown quality, I want to kind of harp on that a bit. Not knowing the quality, that's going to lead to unnecessary care and more dollars as well. And with having it so convoluted, you have a patient looking at their EOB, they don't understand it, they don't know why it's costing this much. I'm an anesthesiologist, and so I'm used to the surgeon blaming me if the patient has hair loss 6 months later. Literally, that's happened to me. I get blamed for it. That's probably anesthesia. Yeah, I had no idea. So I'm sure employers can be used to, okay, well, this isn't necessarily their fault because of the terrible payment system, but they're involved in it intrinsically, and so they get blamed for it as well, and some of that gets pushed off to the employer and employee dissatisfaction. So the kind of the themes with that are lack of transparency. It's not clear, and so a little bit more delving into that. We have the networks. How they try to muddy the waters is that they battle on discounts, and so a discount off of a imaginary price is not very helpful to allow you to compare apples to apples, which is where we all want to get to. That's what you should be doing if you're a CFO and if you're looking at what the right path is for you. And so we've literally heard stories through our travels about insurance companies that say, hey, we're battling with Anthem on this, and we need our discounts to be higher. And the hospital's like, okay, we'll just increase our price. And now your discount's higher, but the price went up, so everybody wins. Everybody wins except for the patient and the employer and everybody who really matters. So that's a terrible problem that is why it also goes into the next one. If we're changing the variables that we're looking at, then that's not what we need to have. So the next step is that we have people talking about percentage of Medicare, And so this is like the sophisticated conversations that we're talking about. Okay, now we're talking about percentage of Medicare. That's the same everywhere. No, it's not. The Medicare is paid differently at inpatient facilities, outpatient facilities, ASCs, or hospital-owned outpatient facilities, and ASCs all differently. There's a geographic difference to it as well, among other things, subsidies they get and extra payments that they get. So that's not apples to apples either. And so I've never really understood why that is better than, hey, how about just dollars to dollars? Because when you got dollars to dollars, you know that you got the apples to apples. Percentages, the only reason to do percentages is if you're trying to, just trying to make it more simple, and you know you can't get it perfect. There's a reason to do it, but it's still not apples to apples. So how can we fix this? Free market medicine. That's why we're here. Free market surgery specifically with Wellbridge Surgical. We want to inform the patients, inform the buyers, and give them, let them know that you have the information here, you have the data, you can make an informed decision, and you have the prices, the quality. And now you've got free market medicine. And so if you're able to make that decision and you're able to compare things among other different facilities, different doctors, then now we're kind of back to where all the other industries are, where, hey, this is free market. Quality and value should rise to the top, and those places succeed, and the others fall short. And that's kind of parroting what Keith Smith has been saying for years through the Surgery Center of Oklahoma. Again, I mention them. I have to mention them every talk that I do because they have been so helpful with getting us set up and us learning so much from them and how they do things. In 2009, so Dr. Smith has had a surgery center since 1997, and has slowly changed from a traditional surgery center to no insurance, just basically free market, upfront pricing, and transparency. And he posted his prices in 2009, and now I think we went there in 2017, and they had gotten rid of their last insurance contract, and they're doing 5,000 cases a year, and doing great with that. I would talk about quality metrics on here. I did want to talk about that a little bit more specifically with us. When is it Tracy? Is that your name? Yeah. So when you're talking about how it's a more personal touch, you're able to take longer with each patient. We at Wellbridge Surgical, we set up our. It's a brand new facility, but we have you walk in and it's not like, we don't want you to feel like you're in a hospital or treated like a number. It's more of a concierge feels kind of like a coffee shop in the front. No, we don't give them coffee because then they'd have to cancel the cases. But that's the feel that we're going for, and so far I feel like we've had a real hit on that because even as of recently as last week, actually yesterday, one of the surgeons forwarded me a voicemail from one of the patients who had I believe she had a hernia repair. No, she had gallbladder removal, and she just said that she was actually worked in HR at her company, and she said that she's never had an experience like that. It wasn't like any other medical experience that she's had before, and that's what we've been seeing on the surveys that we've been doing. That they've not felt like they've been treated like a number, and that they've just had a lot more personal touch. And so Tracy, when she was talking, I kind of felt that I feel the same, that we're able to do that and to take a little bit more time. And there's a couple reasons why we're able to take that time, and I'll get into that. But with the surgeons, talking more about quality, with the surgeons that we use, they are ones that we've been, that both Dr. Panicki and myself, who's our other co-founder, Dr. Panicki is an anesthesiologist as well, surgeons that we've worked with, know most of the ones on the north side of Indianapolis, and the ones that we trust and think would do a good job and who are independent, those are the ones that we've partnered with to do this. And and so we've had some surgeons ask us if they can come, and we just kind of don't really get back to them because, no, you take 3.5 hours to do a gallbladder, or you have to convert to open way more often than you should, and so we don't say that out loud. That's what we're thinking, but we don't. So we try to weed out, similar to Keith Smith in Oklahoma City, weed out the ones that are less than average, and so that, and also our culture with our nurses and our techs. It's a tough hiring market out there. Everybody probably appreciates. So we get asked that a lot. Is it hard for you guys to get staff? And it has not really been hard. We've known a lot of people from the hospitals that we've worked with, and so they're kind of happy to jump ship like we did. And I think a lot of people are really believing that the system is broken, and that they're really enthusiastic to come help us out. We don't even have to, we pay them a similar amount. They don't have call, and everybody with us feels like they're doing the right thing, and it's a nice feeling to have, nice culture to have. One thing I did want to mention. So this kind of goes into the next one here. So when Surgery Center of Oklahoma got rid of their last insurance contract in 2017, that was coincidentally, like, we came like maybe a month after that. We visited Dr. Smith down there. So he walks us into a room that's maybe half this big, but it's empty. It's got like a couple chairs in the corner, and that was the large room that used to be their billing and their administration area. And so they had gotten rid of it over the years because they'd finally gotten rid of all their insurance contracts. So they were elated to get out of the insurance game. It led to better prices. And so that's why I wanted to share this next slide here. It was like in the movie Step Brothers when they make the 2 beds into a bunk bed, and there was just so much more room for activities at the Surgery Center of Oklahoma. They just had this whole room. They didn't need any more, and so not only does that make more room, but it makes more time. And so that time can be transferred into poured back into the patient, as far as the more personal touch, concierge feel. And so we feel like we're able to do that. I've been to a lot of surgery centers, and I know that our administration area is maybe a fifth of the size of some of the other ones that I've gone to in the past. All right, and that. I like to talk about this, about how we make our prices. This is the opposite of how traditionally the people come along, the systems come up with their prices. They just start off with a high arbitrary number and see how low the discount and see what insurance will pay, and they get all giddy when they'll pay them an amount that will allow them a 200% margin or 300% margin on the case. What we do is we want to kind of start how you normally would in a normal industry. So we want to make a normal margin. When we got into this, we did a feasibility study with one of the local accountant firms, and compared us to a couple of other surgery centers that actually know which ones they are, because I went to them, and one of them showed 100% margin, one is 150% margin, and that's just not. That's the only reason you can do that is if it's a cloaked smoke and mirror system where it's not free market. And so what we do is we look and see. We don't start here. We start over here. Really, we start with the surgeon, because we know we want to get a good surgeon. So we can pay higher than commercial reimbursement, much higher than commercial reimbursement to a surgeon. And the reason you can do that is that most of the cost is the facility. Maybe 90% of the cost is the facility, and for like a gallbladder, more than that actually for a gallbladder. But you can pay a surgeon very well to get the one that you want, which is what we do. We know how much time it takes to do the procedure, and anesthesiologist is pretty much based on time. We've partnered with a pathology group that is very transparent as well, and works well with us. And so then you got your professional fees. That's one part of it. And then you go to the facility. So what's our overhead here? So you got variable and you got fixed costs, and then you figure that part out, and then add in. Not all procedures will have implants, but obviously there is with total knees, total hips, cochlear implants. You add that in. We just have that as a cost. It's not like we don't typically have an inventory of them and have to sit on them, so we just have that as a pass-through, and then just build in a small margin, not 150%, and then that's where we come up with our price. And so we feel like that's the fair way to do it, and that's the opposite way that the systems do it. So I do like to share that slide just to kind of it's kind of interesting to see, okay, how do we build our price, and you'll never get a hospital system to tell you even the first thing about how they get their price. It's just made up anyway. A local example of an EOB that my wife's aunt showed us. She had a carpal tunnel release without anesthesia at the hospital-owned ambulatory surgery center, IU Health Ambulatory Surgery Center, and it was reimbursed in total $9,900 for the surgeon, and you can see the percentage on there. See, it's about it's less than 10% the surgeon gets for the procedure. If they get 610 and the ASC got 9,000, so you can see there's a lot of wiggle room with the surgeon. You could pay them double, and they'd be happy as a lark, and you can really make up all of the cost difference or the cost savings in that ASC side. And so this is just nice to be able to see. I didn't click on it here. So this is nice to be able to see. Just the price difference for Wellbridge compared to $9,900 at the surgery center owned by the hospital, and it just details. Look, you can look at details to see where the cost is going, and where the price is going. It's in the ASC, it's in the facility, and so we can control that. What's interesting about this procedure is that we actually work with this group of surgeons, and so the same exact surgeon doing the same exact surgery at our place, which was built last year versus in the 1970s, it's a third of the cost. So it's just an interesting one to look at. And so a little bit more about us. This is my administrator was very good. She told me yesterday that I should have a picture of the staff, and she sent me a good picture of the staff there. So that's Luke, Maria, and Lindsay in there in one of our ORs. And so we've got 4 ORs. 2 of them are fully functional now, doing procedures. Today we're doing procedures in both of those rooms. Eventually we'll get to 4 rooms, and then possibly go to 6. But I don't know if for a connoisseur of an operating room. It's a pretty nice operating room there, pretty big one that we can do. We do all sorts of different procedures, pretty much everything that can be done on an outpatient surgical basis, same day surgery. Other than ophthalmology, we don't do ophthalmology right now, but general surgery, urology, gynecology, ENT, pretty much everything else. Like I already talked about the surgeons and our prices. And the next one here is where are we? And so this is us up there, right down there. So it's about 7 hours and 7 minutes according to Google Maps. This is about right for us. We took a stop in Chicago though, so on the way back we'll find out. So we opened in December, like I said, and we really have the target patient populations that we have. So self-pay, people that don't have any insurance. The non-traditional insurance, the health-sharing ministries like Samaritan, Medishare, those folks, and the high deductible health plans. So say you have you're fully insured. You have a high deductible health plan. You got a $6,000 deductible, and one of your kids needs ear tubes. That's in Indianapolis. That's going to max out your deductible. You're going to hit maybe $5,500 if you get lucky, but probably $6,000. And our price is $2,380, so you save real dollars there, so almost $3,700 or so. And so those folks, depending on their situation, would save. But really, our main focus is self-funded employers, and that's why we're here today. And talking to them about how do you get informed? How do you get good data? How do you make a good decision? And does that incorporate us? And how can we make that work? We've had patients come so far, obviously from Indiana, Michigan, Ohio, Kentucky, Illinois, Missouri, and a couple referrals possibly from Wisconsin. Haven't had any of them actually come yet. They would have come. There was a couple different reasons that they weren't necessarily good patients for an outpatient setting. So how do we? Our target is the Midwest, basically the Midwest right now, and so would love to have patients come from Wisconsin, and there's different ways to make that work. So how does Wellbridge work with a specific employer plan? A couple different things that we've seen that employers around Indianapolis have done is either waive the deductible and the coinsurance. So we've had one of the benefits groups administers kind of a bolt-on policy to where everything that goes to Wellbridge is waived. So the employer waives it. Obviously it depends. Every case is looked at separately to make sure, does that make sense? Is the savings such that it makes sense to waive all of the patient responsibility, and the employer and the employee wins. We have had some issue with health savings accounts and first dollars, and waiving for a high deductible plan, who has an HSA cannot waive the deductible. Different ways to get around that. One way to not necessarily get around it, but to still create an incentive is to waive the coinsurance. So we're technically in the town of Zionsville, and so the town of Zionsville just wrote it into their plan this month that they would waive the coinsurance. In Indiana, there's a lot of HSA plans, and so they were a little bit hesitant to although it's not punishing the HSA plan versus the PPO, it's still, if anybody looks over there, look across the way, and they see somebody else has something, then they feel like they're being punished. That's just the way we are. So just waiving the coinsurance, saves thousands of dollars for these employees if they go to Wellbridge. So it's a possibility to do just that. I mentioned UHC on there because we are one of the only differences I think we have with Surgery Center Oklahoma right now is we do still we are still in network with a carrier, and that's United Healthcare. Specifically in Indiana, they have looked to decrease the total cost of care, and have been in talks with us for a couple years. And and in March we entered into a participation agreement with them, and they just basically agreed to all of our prices. And so we feel really strongly that everybody should be charged the same amount and pay the same amount. And so whether you don't have insurance, whether you have UHC, whether you're a self-funded employee of a self-funded plan, it's all the same price. And we've kind of taken Keith Smith very seriously on that from the Surgery Center Oklahoma, and that's how we've functioned. I should mention specifically, since we're in Wisconsin today, that there, a couple of the companies that we've worked with, that specifically that benefits company that's a bolt-on policy to self-funded plans, they also would pay for the patient's travel when the patient comes down as well, which only makes sense if you're going to have a patient. If they're making a good decision for you, then you want to make it easy on them. Have a case here for total shoulder replacement, which we did our first one of those last month, and just have a contrast of price here. So the average price around us is about $50,000 for what's reimbursed by the big carriers to the hospital-owned places. And so the delta here is 29.5. And given this, say this plan has a $6,000 deductible, 20% coinsurance, max out of pocket, just kind of making up something there. That doesn't seem too crazy. In this scenario, it makes sense to waive all $11,000 member cost, and it's kind of a no-brainer. But what you have to do, you kind of do have to make these incentives, because otherwise the patient, if they don't feel it right there, then what do they care? Like I said, there are consequences to every decision like this, whether they know it or not. But if they don't know it, they don't feel it there, it's not going to be a decision that they'll make. They'll do the easier thing, and they'll kick themselves the next year about it. One thing I have to mention, because through our talks in the last couple of years, this system's a lot crazier than I thought it was. For sure. Jeff's heard more than I have, but definitely want to make sure that, what we've found is when we're talking to different brokers, advisors, insurance companies, folks, it's really important to choose who you're working with, because what we've done is just aligned ourselves with different brokers in central Indiana that really can get on board with what we're doing with the free market surgery, with transparent pricing, bundling. There are some that say they're all about it, and then there are some that actually do something about it. And you don't know that at first. You kind of have to take everybody for their word at first. But Jeff's making a good list of the good guys and the bad guys, and so you want to align yourself with a good guy. I've got a story about. I may not get the details right on it exactly, but I'll get the numbers right. A broker around us, and I think he had a friend who was up north. There's some sort of they got bought by a company, and they had used him, and they were gonna, but that new company was gonna look at a different consultant or advisor, and that person was a friend, so he said, yeah, this new advisor, they're gonna charge us $340,000, but we think that's a good deal. I mean, they said it's a good deal. They really seem good, and so he already knew what he was up against, and they were like, well, what would you charge us if you did it? And so he didn't say $330,000, it'd be just under. I mean, $60,000 is what he is going to charge, and so there are brokers that are doing that, and you really want to make sure that your advisors are motivated to lower your healthcare costs. What is motivating the advisor? What's motivating the broker? And is that in your best interest? I think it's important to have an open conversation about that, and it's a potentially uncomfortable thing to go through, but it's worth having. And once you get past that, I think you ask for detailed claims, and maybe you guys are already past this point. You guys already knew all this, but to get a detailed data regarding claims and itemization of that, and so you can do an analysis on hey, what kind of savings can we look at here? And when I talk about that, when we talk about analyses, in my mind, what we do for folks is try to get an analysis of what we would offer to them. So we have a list of 300 CPT codes, and you look at your claims data. This is how much you spent on outpatient. These outpatient CPTs last year. If you would have gone with us, this is what your savings is. It should be that easy to be able to make those comparisons, and that's what we want it to be like. So the folks that we talk to, that's what we strive for. And so there are hurdles to be able to to implement a place like us into your plan, and and Jeff may be a better one to talk about these sorts of things. But overall, we believe like the less people involved, the better the savings. And so if it's just a direct contract, it doesn't have to be a fancy direct contract. I think ours is like it's just basically our website prices are what you get. And instead of, if it's a patient who comes off the street, doesn't have insurance, they have to pay up front. So they have to have the we have to have the money before they go back to do the procedure. And really what our direct contract is, okay, it says, well, you don't necessarily have to pay up front, but you're on a net 30, so we invoice you, and then you pay within 30 days. And it's just as simple as that. It's not, there's no, crazy, stipulations to our contract. So the word contract always always kind of gives me a bad feeling. But with these are website prices. You're just agreeing that you'll pay it if one of your employees has a procedure. So Host Care Resources is a company in Chicago that does. They're a benefits company that they'll kind of bolt on to your plan, or they will allow patients to travel, and they'll pay for the travel and evaluate on a case-by-case basis to see, hey, is it worth it to go to Wellbridge for this total shoulder? Does it make sense for your company? And can we find, does it work for the patient? And then Matt's company, Self-Fund Health. I'm excited because we've always got employers coming up to us and saying they have, well, how do we do this? How can we do this? It's nice to have more people to be able to point towards. Be like, I don't have all the answers. Like I said, I could learn a lot from you guys about a lot of this, but Matt's done this before. People have done this before, and it's doable. And so let's do it. And with that, I would ask maybe spend the last few minutes to see if people have questions. I did put our email addresses up there. So Jeff is the one who goes around and talks to folks mostly. I'm trapped in the operating room a lot of days. So he's a good one to ask about those things, about the clinical side and the surgeons. I'm happy to answer questions on that. But any questions people have? I'll get out of the way.
Eric?
Yeah.
Do you do warranties?
So we've just had one of the first companies ask for a warranty, and so we would do a warranty. We just have to look at what the procedure is and see if there'd be a difference on it. Some are more high risk than others, and but no, yes, we're open to that.
So that's your stamp of approval on your quality, right? So you want to promote your quality. Yeah.
It's similar to Keith. I mean, like if Keith Smith, and what he says, there's no official warranty, but if there's anything, maybe there is with like a total hip or a total knee or a total shoulder, like with something like that. But with a smaller procedure, luckily with our metrics, I mean, we just started, like I said, 7 months ago. We've not had any issues yet, so we've not been tested, too much. But so far so good. Yes.
Do you guys do bariatric surgery?
We do not. I got asked that earlier today and then yesterday as well, but I've had to say no every time. So we don't yet. Don't have any surgeons that do that procedure. Yes.
What about PT? So let's say it's someone from Wisconsin, they go by you guys for the surgery, go back home. What does PT look like for them?
So we've not had to run into that yet, but I think we were talking about that. Where's Matt? Yeah, we were talking about that yesterday, right? We have PT within, working with a PT company in Indianapolis, but as far as outside of Indianapolis or going to a long distance travel, there are answers to that, and it's been done before. And so it's been done at Surgery Center Oklahoma. We just haven't done that yet because we're pretty new. But the first one that comes along, we're open to looking at that and working with people who've already done it. It's all doable. Yes.
I got a question, maybe it's more for Jeff, but how are you, one thing I found is a lot of companies that are self-funding, they're with ASO, BUCA type carriers and stuff like that, and it seems like they're still trying to steer away from places like you and Surgery Center of Oklahoma, so I'm just curious like what you guys have done to kind of combat that.
You mean the companies are steering away or the BUCAs?
Because of the network, that they're in.
Yeah.
Even if they're self-funded with an ASO, it's still like, don't go there.
Right. Ours is a little bit, yeah. I assume you mentioned United, they're different, but the other ones are.
United, you were surprised when we met with them, that they were just very, very stoked, to hear about us and to be guiding folks,
is that who you're mostly talking with, or is it like employers coming to you and then you're like, sorry, I can't help you because this is your network or this is your situation?
Yeah, it's really Anthem's the only one right now. When they come and they say, hey, Anthem, then we have a specific TPA that we refer them to that has a program kind of set outside. But everyone else, for the most part, we've been able to figure something out. We have the Encore network. They're not up here, I don't think, but we've been able to do some things with them and with their TPAs in order to get creative with the plan development.
I mean, they don't like they like their network. They don't.
Your mic's off.
It's off.
Yeah, there's a few minutes ago. Just stop.
But it makes me feel important. So I kind of wondered. I didn't know if. Yeah, with I forget what I was going to say. With the with Anthem. So Anthem, no, yeah, they don't really want anything outside of their network. They want it to all be within their network, and so they get frustrated if you try to go outside for whatever reason. But there are different, like Jeff said, there are ways to do it whether they like it or not. If you want to do it and you're the employer, you can do it. That's it.
In my opinion, as an employer, I should have the right to do what I need to do, right? My plan to make sure my employees are taken care of. Before 2017, I didn't have my employees pay anything in on the premium, and I thought that was the right thing, And then these increases have only made me have to increase what they're paying each month, kind of like what Eric was talking about. $30,000 savings helps for the following year's renewal, right? It's a big deal. So, yeah. Anyway, I could go on and on, but I don't want to. I want to make sure everybody gets their questions.
I just had a comment I wanted to add on Tanya's question about PT. I know that SCO in Oklahoma has a national network that they can tap into an affordable PT option. I also know of a network in Wisconsin that covers most of the state. We have Dr. Voight Smith right in the room for Central Wisconsin. There's a really good independent in Point. So sometimes it's just searching that out, send me an email or something. And, I'm sure somebody knows of a fair priced, high quality PT that we could put in that bundle. But the comment that I wanted to make is just that often I'll bring up, right? So SCO, Surgery Center of Oklahoma. I've had surgery there myself. Know him well, met him in 16. Gotten to know Dr. Keith Smith and Dr. Steve Lanier very well. They were just kind of the pioneers. They developed the model. So sometimes people get aggravated with me and Matt, not everybody wants to go to Oklahoma. I never said that. It's just they're the model. But we also then have local options as well. But we like to throw them in as an option because if you can save some cases, depending on if you're comparing with system or other just independents here, $50,000 or $10,000, depending on who you're comparing with. Usually they'll require a companion, but you can send them down there and back for $2,000 and still save the plan $6,000. It's still worth instead of a zero copay, it's worth an incentive or $1,000 or $2,000. So, and I think Eric had mentioned that SCO, Keith and Steve are mentoring these guys, supporting these guys. They don't view them as competition, if you will, right? They view them as free market, healthy for America, healthy, so they're helping them. And so Wisconsin happens to be one of the top states for SCO. I'm not sure why, maybe it's just all the talk we've had. But if you're wondering, Steve and Keith would not care at all if some of the Wisconsin traffic went to these guys. They want to support these guys, and SCO is stable. They get something like 600 surgeries a month from all over the world. They're stable. These guys are starting out. They've stuck out their neck and want to do something good. So just, and there's way if you don't know how to structure them into your plan, your broker can help, or right, a lot of it's plan design or factoring that in of that flow interruption through a DPC, PT interventions, things like that. But I just wanted to mention that you're not stepping on SCO's toes. Neither are these guys. They're working hand in hand to help them win. So.
We were on a call today with a large employer in Allies in Texas, Oklahoma, as well as Indiana. And so, we just sat on the calls. That's perfect, actually, because you can send your Oklahoma, Texas folks, to SCO, and your Indiana folks up to us. And so we haven't called Dr. Keith yet to tell him this, but just on the way up. But I'm sure he'll be all about that, right? We'll have to work on, So, and
That's kind of how we operate. Yeah, get us our
that's
yeah.
how we-
We'll
that's
figure it
how
out.
we roll, you know, is that we're problem solvers, and so if you get us the first one, we'll figure it out. But we have a really good network and a partnership with a PT group in Indiana who's white labeling Wellbridge Physical Therapy, and they would love to travel with us as we continue to grow. So this won't be our last center, and we'll put more of these up, and so but we need you to bring some business our way. Selfishly asking for that because that way, like Matt was saying, we can be sustainable and we're devoted to continuing to invest in the free medical market and specifically with surgery. And so yeah, bring us that one and we'll figure out how to make it.
I think it's important, Jeff, to mention that when you work in independent direct primary care, like we can help make that magic happen for you.
Sure.
So like all the stuff you don't want to do or hear about, like the preoperative evaluation, the postoperative care, the preoperative labs, the follow-up labs, the stuff that these guys, you know, probably just kind of gets in the way of the surgery center piece, but the direct primary care piece really can coordinate all that care, all that physical therapy, and there's a lot of independents, a few in this room that do physical therapy that you know, we'd be happy to help put that together so that kind of closes those loops. There's going to be the complication that happens. I mean, just how do you manage that and optimize that? So, this is the human body, it's not a robot, right? So nothing's perfect. So you're going to have that bad outcome. The question is, do you prepare? Always when you run into problems, I think, you know, you trained at a trauma center, so did I. That when you ran into problems when you weren't prepared for it, you didn't plan for it, you didn't prep for it, and that's when you had a bad outcome. And you can mitigate most of that. And I think you have a good local partner because you want to keep healthcare local, despite the 5% of stuff to Indiana.
Mm-hmm.
I think that's where you can really optimize what you guys are doing. So when we all work together, we can make that outcome better than it is. Well, let's just say not named independent. So.
Yeah, we love that. You know, that we call it the bookends.